Okay, so hello and welcome to this ARMA webinar on addressing the burden of foot and ankle pain. I'm Sue Brown and I'm the Chief Executive of ARMA, which is the Arthritis and Musculoskeletal Alliance. We're an umbrella body and our members are the patient and the professional groups that work across the whole spectrum of musculoskeletal health. I think there's an awful lot of different professions involved in musculoskeletal health who can contribute to the musculoskeletal pathway. And I think it's often confusing about what different professions have to offer within that pathway. Today's speakers have both got a background in podiatry and will be able to outline what podiatry has to offer and where that fits into a musculoskeletal multidisciplinary team. And we're going to be looking at what does good care look like for foot and ankle pain, both in rheumatology and in other areas of musculoskeletal pain. So just before we start, I want to find out who we've actually got joining us on the live delivery. So I'm going to launch a poll, which the telephone call listener obviously will not be able to see, but everyone else should now see a poll on the screen. And if you can just tell us what your role is so that we've got an idea of who our audience is. So I can see that we've got quite a range, lots of podiatrists, but we've also got GP, commissioner, various others. So we'll just give it another few seconds for people to just let us know who they are, and then I will share the results so that everybody knows the spectrum of people who are actually on the live delivery. So I'm just going to end that now and share the results. So we have, unsurprisingly, podiatrists as the largest group, but it's good to see that we've got quite a range of other people, including commissioners and GPs and patients on the line. So I will now stop sharing that and introduce our first speaker, who is Dr Mike Backhouse from the University of York. Mike, over to you.
Thank you. Just getting the slides up. Brilliant. So yeah, thanks very much for the introduction, Sue, and obviously giving us a chance to talk about foot and ankle problems and foot and ankle care, because it's obviously such a big issue for people with rheumatic and musculoskeletal disease, but certainly from a service point of view, it's unfortunately often overlooked. So hopefully this will help with some of that. So I'm obviously focusing on rheumatoid arthritis in this talk, and everybody listening and watching will be aware that there's been huge advances in terms of the pharmacological treatment of RA, but even with those advances, there's still massive problems and a huge and quite well described burden of foot and ankle pain in people with RA. You can see the figures there from some recent work from Bristol showing that 98% of people had foot problems during the course of their disease, and that, you know, most of those still had current foot problems, as well as the pain and the functional implications of that foot problems. One of the sort of important stats that came, or one of the important figures that came from that was the impact that the foot and ankle problems had on their ability to work as well. So it really does have quite a widespread and profound impact on the lives of people with RA. And we know that, as I say, even in people who are in remission in rheumatoid arthritis, certainly in DAS28 remission, a lot of these people, around a third, will still have active disease and inflammation in the feet. And obviously that's associated with progression of deformity, pain, and all the other problems with it. We also know that there's probably more, because when you look at our ability to detect active inflammation in the foot and ankle, it's actually quite poor clinically, and certainly imaging has shown that there's often a lot of subclinical inflammation going on in the foot and ankle of people who are thought to be in remission as well. So that's increasingly a problem. And also just to highlight as well that the importance really of looking at people's feet, because what we've seen from some work from Utrecht is that there's a subset of people who actually have much more active disease in their feet than compared to their hands, and that it's these people who have the more active disease in their feet that often go on to not have it treated and to end up with more erosions over time, as you can see in the can't see the cursor, there we go, the top line in that graph there. So I'm not going to focus too much on what the problem is in terms of the foot and ankle pathology, but as I say, that we've shown there the impact it has, and as a result of that, foot and ankle management, and certainly podiatry as such, is recommended in a lot of the guidelines. And here we're looking at the most recent guideline for management of rheumatoid arthritis, which came out last summer. And you can see the little quote at the top about what the guidelines actually mean is that it's worth reiterating, I think, that local commissioners and providers of healthcare have a responsibility to enable any clinicians or patients who want to use these guidelines to be able to. So in terms of what they actually say for podiatry, well, you can see the couple of points there at the bottom around all people with RA and foot problems should have access to podiatrists for assessment and periodic review of their foot health needs. And also that there's a couple of interventions around footwear and insoles that are recommended as well. For anyone joining from Scotland, the sign guidelines are slightly more dated now, back from 2011, but the key messages are still the same, that footwear and insoles are recommended, and the podiatry referral should be offered to all patients. I noticed in the chat there that somebody was joining from Australia, so I'm afraid I haven't got the Australian guidelines to hand, but I would imagine the message is quite similar, because that's certainly what the evidence supports for individual interventions. And before I come on to looking at that in a bit more detail, I wanted to just sort of highlight that although we have evidence for the effectiveness of specific interventions in podiatry, and that's why things like insoles and footwear are mentioned in the guidelines, it's also worth noting, I think, that the data that we do have, although it's quite dated now, this is the 2009 National Audit Office data, there's national data looking at whether or not podiatry as a broad service was helpful or not. And you can see that you've got about 85% of patients thought it helped a lot or helped a little, which is quite high up the list. And then also when you're looking at patient satisfaction with the podiatry services, again, it's over 80%. So I think that's showing us that, you know, the podiatry services are certainly appreciated by patients, and there's always good feedback from sort of podiatry services nationally. So we've seen there a bit about what the guidelines say should happen, and the patients value access to podiatry, but unfortunately, as I'm sure you can imagine, things aren't quite as good as they could be. And in terms of what's actually happening across the UK at the moment, the best data we've got is from the National Rheumatoid and Early Arthritis Audit, which was led by the British Society of Rheumatology. And when we looked at the clinical survey they did, looking at the 2014 to 15 data, which was across all the countries in the UK, included, you know, the Channel Islands as well. We looked at access to different professions within the multidisciplinary team, and you can see that, you know, we looked at whether or not they had access to physio, occupational therapy, podiatry, rheumatologists, registrars, etc. And we also looked at the whole time equivalent. Excuse me a sec. Looked at the whole time equivalent and then adjusted that based on the population within the area. And there was a really impressive response rate to this, I think. So we've got data from 98% of the rheumatology units across the UK, and of those, only 17% had access to the full complement of multidisciplinary members, as defined by NICE. And when you look at the column on the right-hand side of the table, you can look at the access rates for the different professions that bring. Podiatry is right at the bottom there. You're looking at less than half of rheumatology departments across the UK were able to access podiatry for their patients. Bearing in mind, almost 98% of people with RA will be having foot and ankle problems. That's somewhat below what we'd hoped. And also the provision of multidisciplinary care is hugely variable across the UK, both within the separate countries and the separate health systems, but also within and between different regions as well. So to try and put that into some sort of context, well, I think we need to be careful that although we're saying how many of these sites had access to podiatry, we're not actually able to say whether or not that was adequate access, whether the podiatry services had the right or had adequate capacity to see all the patients, or what the level of expertise were for the clinicians within that. And I think one of the as you say, the key messages from that was just how far podiatry is lagging behind some of the other professions in the multidisciplinary team in terms of getting access. And that's certainly not something new. It's something that's been documented, unfortunately, for quite a while now. If you go back to Tony Redmond's work from 2006, only less than a third of trusts could refer to podiatry at that point. So there has been an improvement, but we're still talking about less than half of rheumatology departments having access to it. So there's still a long way to go. And on a slightly different perspective to that, when we've looked at how many patients are able to access podiatry, so again, this will also capture things about a service's capacity. It's less than 30% of patients were able to access podiatry when we looked at data from the National Audit Office, but also when we looked at multi-centre cohorts with over 1,000 patients from within England. You're still getting identical figures in this instance. So again, it's far below what we know that the burden is. And although there's obviously lots of pressure on the health service at the moment, and that's widely documented, and increasing need in terms of the patient need as well, there's also, I think, a bit of an opportunity to think more widely here. And I think at the moment that we're in the best position we've ever been in terms of the skills of the AHP workforce. Certainly podiatry in particular has access to imaging and the ability to perform ultrasound themselves, got independent prescribing rights, and there's been quite big drives from NHS England looking at things like the 10-year NHS plan and AHPs into action, and some of their other major policies highlighting the roles that the nurses and AHPs can play in delivering the health service of the future. So I think with these extra skills, there's opportunities to think about services in a different way and make use of these new opportunities. So there's potentially quite a lot of opportunity there, I think, to restructure and reorganise some of the services that are out there already, and where there aren't services, to introduce new services that can meet the needs of people with RA and foot and ankle problems. And again, I think we can think more broadly here, and we'll come to some examples in a minute, but it's important to not just to think about people who might have established rheumatoid arthritis, but we're seeing in a number of places that the impact that highly trained specialist podiatrists can have in early arthritis clinics, particularly where they've got access to imaging and the ability to inject steroids and that kind of thing, and even change systemic medication. There's certainly lots of opportunities there, and new models are evolving. So at the moment, we don't know for sure if any one example of how to run a service is better than any other. But one thing that we do know is that there aren't enough services and there isn't enough access for patients. So what I wanted to do was to give a couple of examples of how different foot health services meet the needs of people with RA across. We've got one from the south coast of England, one from Glasgow, and one from Yorkshire and Leeds in between the two, and I'll go through some of those now. So again, one of the things when we started looking at this that's quite striking is that there actually doesn't seem to be a standard way of presenting what the services look like, so it's not particularly easy to compare one with another. Might be something for somebody to think about in the future, but in Glasgow, they have around 160 whole-time equivalent staff, and this is for the whole podiatry service in the Greater Glasgow and Clyde Health Board, and they work across primary and secondary care, which is different from the others, as you'll see in a second. And they have that's enabled through electronic notes, which I know took a lot of work to introduce. And they work across these 3 tiers, which you can see in the pyramid in the bottom. Tier 1's basic care, and then patients can be escalated up into tier 2 or to tier 3 as appropriate. And they get between 250 and 350 referrals of people with RA per year. Now, as I say, they don't have specialist rheumatology clinics per se, but they do have an orthopedic pathway, which they're able to escalate patients up and down as required. And importantly, I think that within this system here, the people at the different levels have a broad range of skills. So it's not just the case that up in tier 3, that's the only place where they have access to imaging and steroid injections, etc. But they have independent, I think, 24 independent prescribers last check, and they're able to perform steroid injections and prescribe medicines, etc. Across the spectrum there as well. So it's a very interesting way of doing it. Down in Dorset, it's again a very different system. This is just focusing on the rheumatology service, and they have around 800 referrals per year. They're a very small team, only 1.6 whole-time equivalent podiatrists. And they are very experienced, very skilled podiatrists there, but there's not many of them. And also I know that they, despite the increase in patient increase in clinical demand, they haven't had an increase in terms of the staffing for, I think, almost 10 years now, I think. So there's a lot of work there, a very busy team. But they work out of the 2 local rheumatology teams and are very much part of that, but working across the community as well as in secondary care. They do have very close links with the multidisciplinary team there, and they're able to refer in and out of the other services, you can see. And they deliver their care they have these separate domains, and then with each of them they have the very clear pathways. Now, the majority of the work that they focus on there is in inflammatory arthritis, but there's some increasing work that they're doing in the connective tissue disease. And this is just an example of one of the pathways that they have for the early RA, based on a number of the guidelines and the available literature that Rob's pulled together. You can see the pathways through, but one of the key principles that they really are keen on pushing down one is around screening education, and then so that patients are aware of what's available to them, what can happen in terms of the foot and ankle problems, and then so that if they do ever develop a problem, they're able to access the system in the right way when they need to try and get the best results for their patients. And also, for such a small team, I think it's also worth just highlighting how active they are nationally. I know Rob in particular there has done a lot of work with organisations such as BSR, NRAS and ARMA as well over the years. And he's been very active in terms of evaluating the service they've got and then sharing that with others. So I think that was very important. And they've also been quite an early adopter of some work that I think was started up in Leeds, where they looked at looking at patients in a sort of a holistic way, if we call it that, but very much thinking of it in terms of a patient-facing service, where podiatrists were able to use the skills that they've got in terms of looking at digital ulcers in people with scleroderma that they're used to treating on their feet, and starting to look at them in their hands as well. And that again is a growing opportunity that I know certainly they're doing a lot of work on in Leeds and now down in Bournemouth too. So I mentioned Leeds a couple of times, and that's because that's where I was before coming to York. And the service that they've got there is very different. It's based in secondary care, and a lot of what the work they do there is also described as tertiary care. The clinical service that they have now is led by consultant podiatrists and managers there, and they have a number of specialist podiatrists as well, leading the connective tissue work and the hemarthrosis work, linking up with the haemophilia service. But I think one of the key things about this service is that not only do they have these highly skilled and really highly trained podiatrists, but a lot of that development and a lot of that work has come through the clinical academic process that they have there, and that they've developed through NIHR fellowships and the like. And it's not the biggest service in terms of numbers of patients seen, but they do tend to see obviously the higher end of the pyramid in terms of complexity of these patients. So they see around 500 to 600 patients per year, and then it's, you know, patients are split out into the separate clinics and to see the right clinician, so that, again, excuse me, they can get the best care that they need, and that links ideally with the community. I wouldn't say it's always seamless, but I know there's been a lot of work going on since I've left to improve that, and there are now quite good pathways in and out of the community podiatry service. So to try and wrap that up, we know that the provision of podiatry varies a lot across the UK, but it is poor. It's very poor. It's still less than half of trusts are able to access foot and ankle care for their patients. Despite the challenges, there's opportunity now in terms of the extended scope roles, and with the launch of the guideline last year, that may also give hopefully some new emphasis to commissioners and other service leads to try and design models of care that will make the most of the skills that are available to them for podiatry, but also and importantly to meet the needs of the patients they have. There isn't an example of a one-size-fits-all model in terms of what a service might look like. I think it'd be very unlikely there ever would be, and although we don't know at the moment what's better than anything else, there's certainly a lot more that can be done in terms of introducing services, and there are ways of making it work. And I know as well that the people I mentioned from those services would be very happy to discuss with you how their service works if anyone wants more information. We've not gone into much detail today about the actual foot and ankle problems in people with rheumatic and musculoskeletal diseases, but there is, if anyone wants more information, there's a recent book out that looks at that and also looks at a bit more information in terms of designing services and how to write a useful business case and that sort of thing. So I will now hand back over to Sue. I don't know if we're doing questions at the end, I think.
Yeah, I think we'll maybe save the questions until the end. So I'm now going to introduce Professor Cathy Bowen from the University of Southampton, who is going to talk about the work she's been doing to understand more about views of foot and ankle health. Cathy.
Right. Thank you, Sue, and it's a pleasure to be talking this lunchtime about this. What I just want to say to everybody on the call is that I'm funded by the National Institute for Health Research on a fellowship, and also the project I'm going to talk to you has been part funded by the College of Podiatry. So this is independent research, and these are the views expressed of the authors and not necessarily the funders of the programme of work. So how did we get into this in the first place? And I've been involved in rheumatology for many, many years since I qualified, working in the National Health Service in rheumatology and podiatry, and eventually coming into academia. But the resounding clinical problem that comes back to us all the time from patients, and it's what Mike's alluded to in his introduction here, is what patients say. So, they all say, we know having the feet done helps them get around. It helps activities, it helps independence. We know there are issues though, and with the World Health Organization agenda for the public health and to encourage activity to manage problems like major cardiovascular disease, diabetes, and arthritis, people are encouraged to walk and engage in physical activity. And what the patients are telling us is that actually that's all very well, but we end up forcing ourselves to walk through our foot pain. And there are consequences to that in terms of their mechanics, and then what happens to the other joints in the lower limb. And the other thing that, again, was resounding, what patients were telling us, if I have pain in my feet, everything hurts. But my GP will not refer me to podiatry because I do not have diabetes. Now, for us, that's a complete mystery. And from what you heard from Mike's presentation, we know podiatry is good. There's been a huge change in the training and education of podiatrists over the last 10, 20 years. And that shift was something that we thought, well, why are patients not accessing us? What's the problem here? And that's when we got together with the College of Podiatry and conceived the OptiFooT project. That was sort of back in 2014. And what we wanted to do was sort of delve underneath that and really find out why is it not happening? Why are people with arthritis not actually able to access podiatry? And so what the College of Podiatry wanted was actually to know if we were cost effective. And that is a whole program of work in itself. And you have to even define podiatry first to do that. So we went all the way back to the drawing board and started with a proposal that was a multi-phase proposal split into 3 phases. And we managed to get the funding from the National Institute for Health Research to do that. And what I'm going to talk to you about over the next couple of slides are the results of this whole program of work. So it's basically the past 4 or 5 years worth of work that we've been doing. We've focused on demand for podiatry services. We've looked at the supply of podiatry services in terms of what stakeholders want, and also we've looked at integrating the findings to come up with a solution as well to the problem. So to do this, we needed some heavyweights, and we have 3 major institutions, so the University of Leeds, the University of Southampton, and the University of Oxford, fully supported by the College of Podiatry. There's a whole team of people that's been involved in this project, from rheumatologists, GPs, statisticians, health economics, as well as podiatrists. And of course, we've had our patient and public representatives all along the stage in developing the program of work and developing the research. We've had 4 key research assistants that have worked with us on the project to come up with the findings. So I'm going to start with phase 1, which was the quantitative findings. To look at demand, we decided to go to the evidence, and we did a full systematic review of the evidence. Catherine Edwards is actually an archaeologist from the University of Oxford, so she's completely unbiased in this, who ran the project. And we looked at the evidence in PubMed. What we looked for was long-term conditions. We looked for any evidence in national guidelines for podiatry or foot health care for people who have arthritis in particular. What we found was the articles by year. That's the little chart here that you can see. What's really quite good is that since the sort of millennia, the evidence is going up. So evidence for what we do actually is increasing, and that's a really, really good for us. That's a good sign, and something that we thought actually we're on track with that. But when you unpick the evidence, what's happening here, the largest evidence for what we do focuses on diabetes. It focuses on what podiatrists can do in terms of screening diabetic foot problems, and then managing and preventing diabetic foot ulceration and limb amputation. We also found actually high quality guidelines, so NICE guidelines that Mike mentioned for rheumatoid arthritis. The government-led ones have very little or no involvement from any podiatrists. When we looked at the authorships and we scrolled through the stakeholders in those high-level guidelines. We also, the conclusions from that piece of work were that the evidence, it needs to be accelerated. We know we're heading in the right direction, but we need to expand our focus beyond diabetes and really get better evidence into government guidelines for managing people with arthritis. So the next phase, we then thought, well, we've looked at the literature. That's what the literature is telling us. What happens? What happens with GPs? So we explored GP encounters for foot pain, and this was through the Clinical Practice Research Data Link. This is a huge database funded by the National Institute for Health Research, and there's about 15,000 general practices feed the data into this. What we actually found from that was 3% of GP encounters relate to foot pain in some way. What we then did was we took 567,000 encounters and we analysed those. All of those encounters related to foot or ankle pain, because we wanted to find out, well, what are they and where are they going? So of those encounters, you will see here that related to 346,000 patients who had foot pain. 55% female, 45% male. And then in the pie chart here, you can see what happened to those people. The GPs then sent them to, you can't see this here, mostly it was orthopedics. So most of the patients were referred to orthopedics, next physiotherapy, and then half were referred to podiatry and nursing. It's quite interesting. We sort of then want to know why are all these patients with foot pain going to orthopedics? You know, they're people who have arthritis, they say they can't access us, yet they get sent straight to orthopedics. And one of the things we've then looked at is we've taken this to an international consortium. And this is where I was last week in Toronto. We launched this international foot and ankle group to look at the key problem, which comes back to defining foot and ankle osteoarthritis. And there's a lot of work to do in the international community about arthritis, about how we define it using x-rays, how we define it clinically, and whether we should be using new technology. And that is actually the same for inflammatory arthritis as it is for osteoarthritis. But without an absolute definition for what it is and what the problem is, we can't go further and solve it with interventions. So this group is now set up. There's a 5-year plan, which if you go back to the recording, you'll be able to sort of read the 5-year plan at your leisure. If you want to be involved in the group and you're involved in osteoarthritis, we're very happy to include you. We need more people working on this, and that has been a key problem. And it's not just a UK problem, it's a global problem, is that the focus on arthritis so far has been knees, it's been hips, sometimes hands, very rarely feet and ankles. So we've started that. And when we go to phase 2, really understanding stakeholder views in this. So we've got the epidemiology, we've got the quantitative side, we can define the burden, we know what it is, we know the scope, we know the scale of the problem, but it still doesn't help us answer the problem as why these people can't access podiatry. So we went back to patients, we held focus groups in the north of England and the south of England. With patients, we held focus groups with podiatry clinicians in the north of England and the south of England. And then we did one-to-one interviews with GPs and commissioners again in the north and in the south of England to try and get a deeper understanding of what was happening. So the patients value podiatry services, yet there's still confusion over who to seek help from for their foot problems. And that sort of is linking in with the CPRD, with the GP database, in patients being referred straight to orthopedics. And there's a lot of sort of myths and a lot of issues around access to foot care, where patients actually believe now that they can only go if they have diabetes. Their GPs have told them they can only go if they have diabetes to podiatry. And some patients also, in our focus groups, they're still confused over our terminology. And that's a profession that's evolved over the last 30 years from being chiropody to what is now termed podiatry. And that still causes endless confusion with people, where they think the two are different when actually they're not. It was just a name change. And it's the fact that podiatry scope of practice has advanced so much over the last 30 years that the two probably are quite distinct, yet some people still retain the name chiropodist because they're frightened of losing the people that still go to see them and understand what chiropody is. And then from the patients, we had conflict. So some patients who had inflammatory arthritis got access to podiatry very quickly, rapid response. Yet those who had hip or knee replacement because of osteoarthritis couldn't access those foot care services. So there was very much a difference when we took patients who had rheumatoid arthritis or those who had osteoarthritis. When we went to the podiatry clinicians, we thought, well, what do they say? And there's a lot of things here about culture, condition versus complaint, and what we need to do in the future about transforming and sustaining podiatry. So partly, historically, podiatrists believe commissioners didn't quite get around to finishing off writing specifications. They didn't quite understand what podiatry could do or the whole range of podiatry. When they looked at condition versus complaint, something that really stood out was that if you were a rugby player with diabetes, you could access podiatry, but if you were a 82-year-old lady who had foot arthritis and in need of care, you couldn't. And then in terms of transforming and sustaining podiatry, podiatry is still very much one-to-one, it's still very much embedded in a traditional approach. And we need to make I suppose, a future shape of podiatry as leaders of healthcare, not sort of completely owning it, but being almost the people that are the people that signpost to various aspects of foot healthcare, and they're the ones who keep the complicated things. And I shall come back to that in a minute, because that was basically when we went to the commissioners and what the GPs said. Sort of similar, but parallel to the podiatrists. And in this one, of course, you'll expect finance as a key theme. Understanding podiatry scope was quite strong in this one. They talked about barriers to foot care. They gave us some solutions and facilitators to foot care. And then the final theme about systems working together. I'm just going to spend a moment going through these ones because it helps us understand more about why we've got to where we have in patients with arthritis not accessing our services. So in terms of finance, as Mike mentioned, there's variations in services, and across the country there's variations in cost effectiveness of podiatry. And one commissioner said even in their own in their own area they had 2 podiatry services that offered different cost effectiveness and productivity. They also talked about split systems of care, and that if you're in the acute sector, then it's very easy to cost the service. It's very easy for patients to access that service. But in the community, the pathways are much more muddy, they're more complicated. And that's probably where the confusion comes in, and perhaps some were giving us an explanation that that's perhaps why GPs just go straight to orthopaedics, because it's too much of a muddy pathway to get patients into the system that they need to. And of course, the variation comes back to the local population needs. So in our area in Wessex, you've got the New Forest, which is the oldest population in the country. And yet in the north of the patch, up Basingstoke way, you've got a very young population and a new population that have different needs. So in terms of the variation in what happens, again, it's up to local podiatry departments to produce their business cases to suit those needs. Now, in terms of podiatry scope from commissioners and GPs, they believe we have a split system, and most of them mentioned it's either diabetes services for foot care or musculoskeletal, or some called it diabetic foot service or non-diabetic foot service. They definitely understood the roles of podiatry. That's not a problem. They know what we do. They know the advanced scope of practice that podiatrists can have. And what they really wanted was, again, podiatrists as leaders of foot health services. So embracing way more than just podiatrists. They're embracing a whole range of workforce that are focused on managing foot health for people who have arthritis. Barriers to foot care that they mentioned, very much the traditional clinical approach encourages dependencies. So you've got a one-to-one in a clinic, and GPs, podiatrists, what they all do is at the end of the encounter is almost like, well, the podiatrist will book you back in 3 months' time. And it's that continuation of dependency. Oh, we'll see you again, we'll see you again, we'll just keep that care going. And that was something that most of the people in our focus groups and interviews wanted to change. The delays in referral come back to the other theme linked back to limited knowledge of other services. So yes, they know what podiatry does, but they don't know what the other services are that they can access for their patients. And then particularly for this community of people that are on the webinar, I thought this was quite striking, that a number of people said the arthritis foot doesn't get anywhere near as much support because we're never asked to. So something's happening in the system there where people who have arthritis, they're not complaining, they're not sort of providing a business case, or they're not going to funders to say, look, we also need support for our foot health care. So that's really something that we need to focus on in the future. And that's where facilitators to foot care come in. We need to get nice guidelines, what they want. Commissioners, GPs, they all use nice guidelines. They all use evidence in terms of how to commission their healthcare for their populations. So without anything in nice guidelines, without any foot healthcare guidance for them, they can't show their outcomes of cost reduction. Next, they run stakeholder events, they run patient consultations, but that's not what the patients were telling us. So there's something running parallel there in that they believe they are asking the patients, but our patients who have arthritis are telling us they don't have a voice and they're not heard. So that's something we need to address as well. Something that everybody agreed on was increasing focus on supporting self-management strategies. And actually not just giving patients a bit of information to say, go, this is how you manage your foot health. This is how you look at your toenails. This is how you look at, this is the insole you get for your foot pain. It's much more about signposting to different people, helping them understand who to go to for their foot health. And that comes all the way back to systems working together, which was the final theme in this one. Again, very interesting that with the new block contracts coming in for GPs, there'll be different service configurations. We can have podiatrists as first contact practitioners in GP practices like the physiotherapist, but more focused on lower limb pathway and arthritis. We can also look at health and well-being objectives for this person and get the podiatry leaders involved in that, and then bring in all the other clinicians that need to be involved with that objective. So briefly, the impact of that was great because I was so pleased over the last month, Foot Health Month, April 2019. The College of Podiatry have taken on board all of this information and they've gone out to GP practices. So they've started reaching out to GP practices. They've secured funding to get out there, engage with the nurses and general practice managers to ask as well about what support they can give for primary care. They've given information, they've got web support for GPs and nurses, all explaining what podiatry can do. And I'm hoping those links will work because they will take you to the articles and the blog posts. And this goes back to the evidence from our core podiatry project that they've used to move this work forward. So where we go from there, we've made up a lot of ground by understanding what the problem is. So we really understand the problem now. What we need to do next is try and solve it. And one of the things we've looked at is a barometer of foot health needs. And you just have to imagine a first signposting pack like this, so a little leaflet. This is one from the University of Southampton that I've just taken a copy of, because we want to do what's called a barometer of foot health needs that will help patients signpost. So, and it will go all the way from social foot care needs through to tertiary foot care needs, and helping any stakeholders, so this is for everybody, any stakeholders signpost people who have these type of foot conditions to the right clinicians. And the barometer of foot care goes through this, and you can access each page very quickly by that flip open booklet. And this is also transferable onto the web. So this is something that we're just developing. We're just about to start a feasibility trial of it. And if the feasibility trial is successful, then we're going to take it to a national trial. We'll be working with Mike and the unit of York to do that. And it's whether we work with GPs at first contact, or whether we go and spend the time with pharmacists as well, whether it's a prescription type intervention. And that's what we're going to determine in the feasibility trial. So that's where the project is up to. And that's work over the last, say, 5 years worth of work. It's not going to stop. We have a whole team of people to continue this work as well now. So although it sounds like a long time, and it sounds like for people who have arthritis, it's really hard to access the survey. So I just want the message to get out there that we are working on it. And we're always happy to have any contact from people, any advice. And I've put on this last one, you've got my email address there. So any suggestions for future on where to take the work forward, then I'm more than happy to receive those. Okay, so thank you very much, and thank you, Sue and Alma.
Great, thank you very much, Cathy. So yes, that's two really interesting presentations. If anybody has any questions, please do put them in the Q&A box. If you've got any comments, or if there's anything that you'd like to share with other participants that you'd like to do as a result of what you've heard or explore further, then do pop those in the chat box, and we'll deal with any questions that come up as they come through. As I said, you will be getting an email from us if you registered for this webinar, and we will pop those links to that article and blog that Cathy mentioned into the email, so that you don't have to plough your way through the presentation to find them. So yes, any Q&A or any questions anyone wants to ask of either Cathy or of Mike. I thought that was really interesting, Mike, setting out those three different ways, very, very different ways services are provided. And then Cathy touching on some of the things that have been going on in the NHS at the moment about transformation, about different professions interacting in a different way and maybe taking leadership roles that they haven't taken before. Mike, I don't know if you've got any comments on whether you think the different models that you were outlining are likely to be changing in the light of the long-term plan.
I guess.
Putting you on the spot there.
I was going to say, yeah, well, nothing ever stays the same. Yeah. So it will change. You can guarantee that in the NHS, there'll definitely be some change. But in terms of how they change, I'm not sure, because I think the opportunity is definitely there in terms of the extended scope roles, and I think there's perhaps not as much evidence around the effectiveness of those at the moment as there could be. And I think if there was more evidence, then I think then it would be easier to make the changes that are needed to enable the people with the advanced skills to help patients out. I think the other big challenge I think we've got at the moment is that there's because of the change in tuition fee, there's less students going to study podiatry at the moment, which I think maybe Cathy would be a better place to talk about, but that's going to potentially result in a drop in the number of podiatrists going through the system. And if we haven't got enough at the moment to provide the foot care we need, what are we going to do when there's even less? So I guess the bottom line is, yes, there's going to have to be some changes, but what they are, I don't think we really know.
Okay, and that leads neatly into the first question we've had, which is Mohammed saying, I've been trying to look for some courses specific to podiatry and rheumatology, and I can't seem to find any. So do either of you know any courses that are specific to podiatry and rheumatology that it's possible for people to sign up to?
So is that from a podiatrist?
I don't know. Are you a podiatrist? If you could just pop that in the chat box or the question box,
yeah,
and let us know. I'm guessing it's a podiatrist who wants to specialise.
There's a master's module at the University of Brighton. I think still in rheumatology, which is excellent. It will give the podiatry focus and sort of an exposure to imaging techniques as well. There's also BSR, the British Society of Rheumatology, for an ankle course that's run through Leeds. So probably Mike you must have been part of that. Yeah, that's probably the one to do, isn't it?
Yeah, unfortunately that's not run for a year or two now. But certainly, I mean, that course was aimed at all professions. It was we used to get a lot of GP rheumatology registrars as well as podiatrists coming in, and physios and nurses as well. And obviously different professions got different parts of the course they found them more helpful than others. But yeah, I'd certainly love to see that running again. But I think the BSR need to kind of, because it's a BSR course, they need to initiate that. But in terms of other learning, there used to be quite a good free information leaflet from Arthritis Research UK aimed at podiatrists, or aimed at clinicians, looking at sort of ankle problems in rheumatology, but I'm not sure that's still available since they've changed to versus arthritis. I couldn't find it this week when I was looking for it. There is, of course, the book that's just been published. That Cathy and I were both involved in writing this for, but neither of us get money for it, so we're not trying to. There's no conflict of interest there, but that's been written by experts from across the world looking at ankle problems in rheumatology. So that's certainly a good place to look.
Yeah. I'd probably say University of Salford and Glasgow Caledonian University also have modules that will focus on advanced clinical practice and rheumatology. From what I know with colleagues here at Southampton, we focus more on the research side. So we have interns every year. So each summer we have interns funded by Versus Arthritis who come and work with the team over summer. And then we help them in the future to get more funding to become clinical academics. So we do the sort of mentorship and the training, and we do that across the country in combination. So we have Leeds, we have Salford, Glasgow Caledonian, University of the West of England, Oxford, and Salford. So that, yeah, involved in that scheme as well.
Okay, and if we find links in time, we will add links to some of those courses and resources in the book into the email that we send to you after the webinar.
Mm-hmm.
So unless there are any last questions coming in, can't see one at the moment. I'd just like to thank you all very much for joining in this webinar. I'd like to thank Mike and Cathy for the time to deliver it, and thank you all very much for supporting us. Do look out for future ARMA webinars. We have a regular series. We try to do at least one a month on different topics about musculoskeletal health. So please do look out for those and sign up to our newsletter in order to find the details of the future and upcoming ones. Thank you all very much, and goodbye.
Thank you.
Thanks.